about 12. Oh, it is 12:02, and we are going to get started. I suspect more folks will hop on in the next few minutes. Welcome, everyone, to the first of 4 quarterly webinars for Define Colorado. Today, we are focusing on infant sleep wellness and safety during and after NICU hospitalization. I'm Susan Huang, neonatologist at the Anschutz Medical Campus, and I am joined by Emily. Would you like to introduce yourself?
Sure. I'm Emily Fawaz. I'm a NICU mama to twin boys who were born at Children's in Denver. And I'm also an occupational therapist, and I work in early intervention. So I get to wear both hats today.
All right, awesome. So how this will proceed, I will start with a brief introduction on SUID or safe sudden unexpected infant death, share some epidemiology, both nationally and affecting our preterm population. And then most importantly, the bulk of our hour will be led by Emily and her sharing her experience related to safe infant sleep and how she navigated that very difficult time after NICU discharge. So let's start with some definitions. SUID, sudden unexpected infant death, is death in an infant less than 1 year of age that occurs suddenly and unexpectedly, and whose cause of death is not immediately obvious prior to an investigation. Versus SIDS that you might have heard, or it is more commonly referred to, sudden infant death syndrome, death of an infant less than 1 year of age that cannot be explained after a thorough investigation. That includes a complete autopsy, examination of the death scene, and review of the clinical history. So ideally, you have an infant that comes to the hospital, cause of death is not clear, and you do a thorough investigation, and you can then categorize that death into these buckets. Maybe you do a thorough investigation and you still don't know the cause, and then it's SIDS. Is it from unsafe sleep or something that caused suffocation, accidental suffocation, infections or other medical conditions? But you see this bucket here, unknown, and you're thinking, well, I just said that SIDS is you do an investigation and you don't know the cause of death. And what's that difference between unknown? It really depends on what state, county, jurisdiction you live in. Every medical examiner has different criteria for what they call SIDS versus an unknown. So an unknown potentially could be that in one county, a complete investigation was not done. There was no autopsy performed. And so without that, they're not able to call something SIDS. So it really does depend on where you live and where that death occurs. That being said, annually in the US, about 3,500 infants suffer SUID. And in 2020, the most recent year that data is available, 1,400 of these deaths were reported as SIDS, 1,100 as unknown, and 900 accidental suffocation and strangulation in bed. The reason that it's such a tricky thing to define is that we don't have one cause for SIDS. We don't have one mechanism of causation. What we do have are risk factors, and the most widely accepted model is this triple risk model that posits that you have a vulnerable infant during a critical developmental period who then has an outside stressor that then leads to SIDS. So some intrinsic characteristics to the infant: prenatal exposure, such as tobacco smoke. The medullary serotonin system has been implicated, genetic background, and then what we're going to focus on, prematurity, as well as intrauterine growth restriction. Now, what I think gives me more hope is what are the extrinsic or modifiable risk factors where we can do something to engage with families is to reduce the risk for SIDS or SUIDs. We know that breastfeeding is protective, reducing smoke exposure is also protective, making sure that the infant is not overly hot also reduces the risk, and then safe infant sleep practices is protective. So shown here, we see SUID rates by cause from 1990 to 2020. In orange is overall SUID, so that combined SUID rate. In blue is SIDS, the orange is unknown, and the green is accidental suffocation, strangulation in bed. What you see is that we see this decline in SIDS, which really started to happen in the mid-1990s, really attributed to the Back to Sleep campaign. That was an incredibly successful public health campaign to reduce infant mortality. You see this continued decline from 2010 to 2018, but you also see this increase in the unknowns and the accidental suffocation, strangulation in bed. And that's really due to a diagnostic shift, meaning what we used to call SIDS, we're now calling suffocation or unknown based upon new criteria for what we're naming these things. So that being said, in some, we've actually had no improvement in SUID rates in over 20 years. And so why do we care about SUID? You know, it's infant death, yes. It's also the third leading cause of infant mortality in the US. Here you see causes of infant death, 2005, 13, and 14. And you could see that SIDS is the third leading cause after congenital malformations and then short gestation, low birth weight, so like prematurity. But I think what's really notable about SIDS or SUIDs is that it's potentially preventable, right? So for low birth weight, that baby is born and in your unit, you're not going to change, at least not in the short term, the preterm state of that infant. But is there what we can do a whole lot when it comes to SUID and SIDS? And while SIDS is the third leading cause of infant death, it's the leading cause of infant death after the first month of life. We know that there are unconscionable inequities in infant mortality rates by race and ethnicity. Here we see rates for 2019. So our white population has a rate of 4.5 deaths per 1,000 live births. Compare that to the non-Hispanic Black, which is more than double at 10.6. The other group that is heavily impacted are the non-Hispanic American Indian or Alaska Native groups. And those same disparities or similar inequities are present for SUID as well. Here we see SUID death rates by race ethnicity combined for 2015 to 2019. In blue, it's SIDS, orange is unknown, and that green is accidental suffocation, strangulation in bed. So again, you see really unconscionable inequities in the rates of all three of these SUID conditions. Now, I highlighted that preterm birth is a significant risk factor for SUID. Shown here, we see preterm birth rates in our country from 2007 to 2020. This is probably familiar to many of you, but on average in the US, 10% of our infants are born preterm. We've seen some slight fluctuations in preterm birth rates, you know, with some decline in 2012 to 2014. And then again, in more recent years, it's starting to go back up. The prematurity and SUID. So, you know, that association has been shown in several studies. This was a study that linked infant birth and death certificates and then tried to understand what were the risks for SIDS, suffocation, and other by gestational age categories. So for those of you that are not as familiar with statistics, is that here in the full term group of 37 to 42 weeks, you see an adjusted odds ratio of 1. So that's the comparison group. And so for the infants at 33 to 36 weeks, their risk of SIDS is 1.85. So they're 85% greater odds of suffering SUID compared to infants that are born full term. And you could see that that risk just increases tremendously in younger gestational age groups. So between 2007 and 2020 in the US, nearly 12,000 preterm infants experienced SUID beyond the first month of life. And this number is really shocking to me because these are preterm infants that survived those acute, really tenuous first several weeks in the NICU when you're really worried about pulmonary disease, cardiac disease, severe infections. They got through all that and then they died from SUID. A potentially preventable death. And so this is what really kind of motivates me to think about how do we do better for our preterm population. I'm going to share a little bit more data about preterm infants and the risk for SUID. You know, a lot of the studies focus on full-term infants or even more broadly, all infants, and we know less about the preterm infant group and SUID. So with American SIDS Institute funding, we undertook an analysis, again, of linked birth and death certificates from all 50 states from 2005 to 2014. So the first thing here is, here we see unadjusted. So, you know, we're not taking into account anything when I say unadjusted, right? It is what it is. And then adjusted SUID rate. So this is accounting for, you know, income and education and other factors that we know are associated with SUID. The first thing that I'll highlight is this number. So based on our sort of algorithm, we identified over 8,000 preterm infants that experience SUID. The other thing I'll highlight is that continued unconscionable inequities. So here we see that in our entire cohort of preterm infants, non-Hispanic Black infants comprise about 20% of our cohort, of our group here, and yet they are overrepresented in the SUID group at 35%. So we have more Black infants that are proportionally dying of SUID than other groups. The other thing that you'll note is that when we compare across racial ethnic groups in the adjusted analysis, we account for things like we know that Black mothers are more likely to be publicly insured, lower education, a number of other risk factors that are due to centuries of racism and structural racism. And even after we account for all of that, Black infants and Alaska Native American Indian infants are still so much more likely to experience SUID than white infants. So there are these persistent disparities where we know Black infants are 1.5 times more likely to be born preterm. Preterm infants are 2 to 3 times more likely to suffer SUID. We have Black infants that really bear an overrepresentation of the burdens of complications of prematurity. And then even after they go home after the NICU, they're more than 50% more likely to die from SUID than white infants. So there is this magnification of disparities and inequities over time. So what are we asking families to do? So in 2022, the Safe Infant Sleep guidelines were updated by the American Academy of Pediatrics. It's a very long document, but in short, the sleep space and practice has to look like this, where an infant is totally flat in a firm mattress in a separate sleep space with nothing else that's in the crib. There is a similar kind of parallel document written by the AAP that's really focused on the NICU patient. And yet I feel like this document is less well known, that in fact the AAP has endorsed some guidelines, some recommendations for how we start to model safe infant sleep in the NICU for a better transition home. Despite that, I think this is what's very common in the NICU, even for a well-grown infant that you see here who has no medical equipment on their face. I don't even see an NG tube, but the baby's got every unsafe sleep item you can imagine and is side lying. Similar here, the baby just has an NG tube for feed, so is absolutely eligible for safe infant sleep, and yet has all of these items, and it's probably with the head of the bed up, I see there with a gel pillow on the back of his head. So we're modeling all these unsafe sleep practices, and then on the day of discharge, we tell families, don't do whatever we did here, you do what the AAP recommends. And then don't even get me started on all the devices that are on sale, that are for sale, out at Target and Walmart, etc. So the Rock and Play, for instance, is actually like banned by the FDA. And yet it's still sold, it's still visible even in some NICUs, including my own. And so there's still a lot of work that needs to be done. And so why we're launching a Safe Sleep Collaborative within Define is that we know we can do better. And so I did some of this work in Massachusetts, really focused on improving safe infant sleep practices in Massachusetts. We started off doing this work in 2 NICUs at South Shore Hospital and St. Elizabeth's. And really what was critical is that we all agreed upon an algorithm that we said, if a baby meets these criteria, then they're ready for safe sleep. So when we first started, we used very kind of liberal, I would say, our bar for starting safe sleep was, pretty low. So for us, it was a baby greater than 1,800 grams, more than 34 weeks, who didn't have medical conditions as well as equipment, and then was in an open crib. If you met all these criteria, then you can engage in safe infant sleep. The other key piece was a double-sided crib card. So on one side, infant therapeutic positioning. So we know that a lot of the infants in the NICU are not ready for safe sleep. And so there is a card which highlights to staff and families the reasons why the baby may not be eligible and what some of these unsafe practices might be, and that it's not recommended for home. Then once the baby is ready, it's almost like a little celebration. It's a milestone reach because the baby has matured and is that much closer to going home. You flip the card and now the baby is ready for safe to sleep. So these are the results from our work in those 2 units. We looked at being positioned supine, flat positioning, free of positioning devices, and that crib area empty of dolls and fluffy blankets. And then on the left, overall. What you'll note is that before we did anything, only 25% of our medically eligible babies were engaging in all of these safe sleep practices. And then by the end, our compliance rates had increased tremendously. What was exciting is that we then took this work to every NICU in Massachusetts, as well as some level 2 nurseries. And each bar here represents a different hospital. And you can see that the compliance rates for safe sleep vary tremendously, from like less than 50% up to more than 90%. So lots of variability and therefore room for standardization. And so we implemented this in every NICU in Massachusetts, and this is our overall compliance over time process control chart. With over 7,000 cribs that were audited, we see that overall compliance improved from 47% up to 80% during this time period. What was really, kind of gave me hope was that the variation was reduced. Here we see each of these black lines are the compliance percents over each year of our project period. The dashed lines are the confidence bounds, and each of these black dots is each NICU. And so you could see when we first started, each of these NICUs were far away from that compliance average. They were outside of the confidence bounds. They were just all over the place, and there was so much variation. And then by the end of the project, nearly all of them are huddled towards that 82% average, so with a reduction in variation. And so, while that in-hospital work was great, we actually didn't follow these families post-discharge, and we don't know whether or not what we did in the hospital mattered at home in terms of changing family behavior or encouraging families to adopt safe sleep practices. And so Meg Parker and I, who is a neonatologist in Massachusetts, we are in the midst of a 5-year national study to better understand factors that influence maternal decision-making around safe sleep after NICU discharge for preterm infants. And so this is a mixed method study. We have some qualitative and quantitative. The qualitative piece is done. And so we're really focused on using this theory of planned behavior framework, that we know that one's attitudes, their subjective norms, and their perceived control over a situation influences their intention to then carry out a certain behavior. What we found in our study is that for attitudes, mothers' fears about their infants being vulnerable and small in their preterm state related to suffocation, apnea of prematurity, and reflux influence their practices. Their subjective norms were influenced by the education they received in the NICU and then advice that they got from other providers, family, friends, as well as the media. And then in terms of perceived behavior control, mothers actually adapted the recommended infant sleep practices to meet their own needs and comfort. So there were some families who say, like, I'm the only one who could keep my baby safe, and so the baby's going to sleep right next to me, on the bed. And I know that my husband is a very deep sleeper and is going to roll over the baby. So I'm going to sort of cocoon the baby with my own body to make sure that that doesn't happen. So it was families really doing what they felt was safe for their baby. So for the quantitative, these are just very preliminary findings. So we've recruited over 1,000 from the 1,500 planned of preterm infants from 30 US hospitals. And so we conducted a survey 4 to 8 weeks post-discharge. And what we find is that 50% of mothers report non-supine sleep, so belly sleeping or side sleeping, and bed sharing was happening at 23% of our cohort. And in the final week of NICU stay, only 35% of mothers observed their infants exclusively supine, and then 62% observed loose objects in the crib. And education by NICU providers influence maternal decision-making, but over 20% of mothers reported that providers supported non-back or non-supine positioning. So what this is showing us is that we've identified modifiable factors that influence maternal decision-making that we can then develop an intervention study to actually address. Okay, I'm going to skip this because I really want Emily to have the majority of this time. This is should be familiar to many of you. This is our defined key driver diagram. And I just highlight this to say that this very, very bottom box, that one of the key drivers was focused on family participation in discharge planning. And our measure of that is parental report of safe sleep adherence after discharge. And so this is the data that we're collecting over time that will inform the safe sleep related work that we're going to do. Our preliminary data that we have based on 6 hospitals that are participating certainly highlights that we have room for improvement. So here on the left, you see, I'll bring your attention to this light blue bar. Families are reporting what they're seeing in the crib just before discharge. And so they're still seeing burp cloths and stuffies and blankets, which, ideally we should really be modeling full safe sleep. And on the right is infant sleep positioning. I'm going to bring your attention to the orange, the lighter orange, which is what families are observing just before discharge. And they're still observing some stomach sleeping. And then at home, you see that not everyone is necessarily doing back sleeping. So then we made this composite measure is if you're compliant with all elements of safe sleep, that means you're overall compliant. And so we asked families, what they observed, as I mentioned, around the time of discharge. And so I'm going to bring your attention to this orange line. So no family in any of our units report that they saw full safe sleep compliance during just before discharge. This number still astounds me. So none of our families are observing fully compliant safe sleep positioning and environment at the time of discharge. So clearly there's a lot of work that needs to be done, and we're really excited to embark on that. But I also recognize that this is the reality, right? Where these babies, they don't sleep as we want them to sleep. Their sleep schedule is not the adult's sleep schedule. And so how can we best support families in this transition home? So I'm going to stop there and let Emily take over. I'm going to stop sharing so that she can share her screen.
Thanks, Susan. Let me get this going here. Let's see if we can do it this way. Am I sharing? Here we go. Sorry, 1 second. Technical difficulty here. I can't exit out of these.
Now.
Okay, great. Alrighty, and this should be okay. So thank you, Susan. So what I want to talk about today is a little bit about what sleep looked like for us in the NICU, but then spend more time talking about some of the barriers that we had with safe sleep guidelines and just looking into the research a little bit about what we're finding with those barriers, talk about sleep deprivation for parents and this idea of parents being overloaded with information as a barrier. But then I want to spend some time talking about what parents can do. What are some tools that we could give parents, and more so giving an idea of what could support look like for families when we're sending them, out of the NICU. With the hope that they're following through with these safe sleep guidelines. So again, these are my twins. They were born at 28 weeks, and we spent 4 months at the NICU. And I won't spend too long, but we definitely, our story is consistent with the findings that you all had, Susan, with the boys' beds were raised, they were sleeping on their belly, and we'd see them arching from their reflux. So a lot of those modifications, especially while they were getting towards their due date when they were more medically stable, we were still seeing modifications to their sleep environment to help with reflux. And both of the boys up until discharge, they were not fully compliant at the NICU with the safe sleep guidelines. And so I think thinking about this, even from the view of this preparing babies to be ready to go home to sleep on their back so they're used to it, all the safety things are important too. And just the idea that they might sleep a little better because they've been sleeping on their back for, as much time as possible would be such a gift to parents, because we went home and we had no idea that we could be as tired as we were when we got home. I mean, our boys didn't. We weren't able to not wake them every 3 hours for about 12 weeks of being home. So there were our nights, there were nights that we got less than an hour of sleep cumulative if we couldn't get them to fall asleep, and we're holding them and bouncing them and trying to sleep. And so for us, those first 6 weeks of being home was a real struggle. And we did struggle to be compliant with all the safe sleep guidelines. And I remember at the time feeling like, well, we're doing the best we can. We're doing most of the things. But now looking back on that, it's like, if someone told me like, well, we put our kid in the car seat 80% of the time, that's pretty good. It's like, we wouldn't have that reaction, because like every time your child's in the car, they should be in a safe place, because of the risk that a baby has in the car. And the same applies to safe sleep. And so I'm excited to be partnering in this project, because how can we help empower parents and give them tools so that they can comply? This is just a little snippet of coming home, and we had friends come help us feed, and we made 16 bottles a day. And I mean, we were up to our eyeballs in twins and all things NICU. And so how do we help families with this adherence? And so first I want to dive a little bit into what Susan touched on, but like this idea of what are parents doing at home? What is the adherence right now for safe sleep? And so I found some studies as well. This one was done in the US in 2018, and it looked at 250 parents with at least one child under 6 years old. And one thing that I found remarkable was that almost 70% of the families reported having had a conversation about the safe sleep guidelines with their provider, and only 20% were reporting adhering to those guidelines. And so they've said some of the barriers or some of the characteristics that played into that were trusting the provider, comfort talking about the guidelines with their provider, their agreement with it, and the self-efficacy to follow the guidelines. So what I took out of looking at this is like, there's a percentage of people who aren't hearing about the guidelines. That's one area where we could help. There's a percentage of people who aren't trusting the guidelines. That's another area of intervention. And then there's a percentage of people who, and I fell into this, and I think a lot of parents fall into this, that we trust the guidelines. There's the intention to follow the guidelines, and then they're not. And so what is happening with that group of people? And so I looked at another study, which I really appreciated. It was done in Australia, which has similar safe sleep guidelines to the United States. And what I appreciated about the study was that it was a qualitative study. And so it asked parents, what are the challenges you're experiencing in regard to each of the guidelines? And so two of the most challenging guidelines that parents reported having trouble adhering to were the infant sleeping in their own space, so not co-sleeping, and keeping the baby in that on their back sleep position. And so when I was reading through these comments, overwhelmingly, this idea of parental sleep was coming up as a big barrier to continuing to adhere to the guidelines. And so one of the quotes that I really appreciated was, some advice or support on how to settle a newborn baby would have been appreciated, but all I was told was to follow the SIDS guidelines. And whilst I know this is important, if your baby will not sleep on their back, what option do you have? And so I looked into, this kind of led me down looking into sleep deprivation. And so it's like, what's happening with these parents? Like, what do we know about sleep deprivation that's this huge barrier to parents? And unsurprisingly, there's a huge impact on cognition and decision-making and executive functioning. So that ability to inhibit your behavior, to assess risk. And so one thing that I found really interesting in one of these studies, were both literature review studies, but was that people who were sleep deprived, and this was short-term sleep deprivation, was that their brain activity was similar to people who had damage to their prefrontal cortex. So that's that executive function piece of inhibition and decision-making. And that notably that decision-making was impaired such that focus is shifted towards short-term outcomes, and that the risk assessment is impaired. And so what does that mean? That means that at 2 a.m., when a sleep-deprived parent is deciding whether to continue to try to lay their baby on their back and follow those guidelines, or, bring them into bed or go hold them on the couch, or those decisions that we know are happening, that decision to not choose the immediate gratification of getting themselves and their baby to sleep faster is requiring vigilance and inhibition and problem solving and risk assessment and all of those things, all of which we know is impaired with lack of sleep. So what do we do about that? Like, how are we preparing parents for this time, that this unimaginable lack of sleep that is going to happen? And I think what is really unique about the NICU is that, we aren't sending parents who have term babies who go home after 48 hours. There's less time in there, right? There's less chance to help the baby get used to sleeping on their back and teach parents and help parents come up with a sleep plan or a plan while their brains might be functioning a little bit better than after they go home and are getting no sleep. So there's an opportunity here. And so I was curious then. I'm like, okay, well, what is out there for parents? If you type into Google what to expect with a newborn sleep, right now is a really interesting time to be a parent because there's so much information available, and it's like everyone is an expert on opposite things, and everything is important, and everything, this will kill your kid, and this will kill your kid, and this. And so I truly believe that it's hard to, when it comes to true safety issues like safe sleep, it's hard for parents when they're inundated with this information to truly decide what is important that I should be listening to and what I can tune out that isn't life or death. Because sometimes it feels like everything is. And then if everything is the utmost, 2 exclamation point importance, then nothing's that important, right? So, but that we know that that's not true. And so I looked into, right now, like if we put on our parent lens, you're a tired newborn parent who is desperate for information on how do I get my baby to sleep. I just want to give a few examples. And with this, I'm not, targeting different organizations. I'm just trying to give an example of, what this might look like from a parent perspective. So when you type in newborn sleep, what to expect, this is one of the first articles that pops up here. And so one thing I thought was, for me and our experience was a little bit like laughable, was that it says after the baby's born, men lose an average of 13 minutes per night, while women lose over an hour of sleep each night. And I tried to look into that research, and it was unclear like what period of time they were measuring, or was it averaged over the 6 years, or that was unclear to me. But truly, like if we're preparing parents for like telling them this is serious, we really need you to be following these guidelines for the safety of your baby, and this is a really hard time. It's a hard thing to do, to be there at 2 a.m. and continue to make that decision. If parents are going in with the expectation that they're going to lose, 15 minutes or an hour of sleep, like I lose an hour of sleep by watching an extra Netflix show. You know what I mean? It's just like, it's so beyond for many parents, that level of sleep deprivation. And then, a lot of websites have these tips, which have the best intentions for parents, but a lot of times they're contradictory, or they can be a little bit vague. And so I think parents get inundated and left not really knowing what to do. And so one thing that stood out for me on this same website was this idea of being comfortable saying no. And I want to highlight here that very simply and vaguely, it says, you can say no to family and friends, but before their 2-month shot, it may be ill-advised from the standpoint of their health. And then two bullet points later, don't be afraid to ask for help when you need sleep or alone time. So from a parent of not knowing what to do, it's like, well, what do you mean I should be afraid for their health? Like, should I be asking people to come over? Like, what if I'm putting them at the risk for that? We need to be very careful about not adding fear and giving parents tools and not having them read this article and be like, well, I don't actually know what to do right now. I don't know what to do with this information. So just another example of like this idea of giving parents tools to use. And in that Cole study, the qualitative study, they talked about how this idea of do's versus don'ts or a checklist is not super effective for parents. And so on the AAP website, when it's talking about the safe sleep guidelines, this is one of the options for an additional article that you can select. And I thought, great. Okay, what is this? A lot of parents, especially a lot of NICU parents, deal with reflux, and it is a barrier to parents and the babies getting good sleep. And so I clicked on this, and quite frankly, it was disappointing because it says you can put them on their back, you can transfer them to a flat, firm surface, and you can't use gadgets. And so these are the safe sleep recommendations, but it's not new information or new tools for parents to use with reflux. It's reiterating what you can't do, not ways that you can work within those guidelines to help your baby. Another just a challenging thing for me with this same concept of like trying to interpret recommendations is that this site talks about, that same website talks about, skin to skin with their mother is really important for an hour after birth. And it says after that, or when the mother needs to sleep or take care of other needs, the baby should be placed on their back in a bassinet with no incline. And then it says, if your baby falls asleep in a car seat, stroller, swing, infant carrier, or sling, you should move them to a firm sleep surface on their back as soon as possible. And then links on the same website, there's a baby wearing article and a skin to skin article, both which kind of demonstrate babies sleeping on their parents in a sling. And so from the parent perspective, this is confusing of when is it okay for me to hold my baby? Can they sleep in a carrier on me? Can they sleep on me in skin to skin after birth? And I say this because anecdotally, when I've been working with families of newborns, there's this, parents are apologizing for wanting to hold their baby sleeping, not when the parent is sleeping, when the baby is sleeping, and just snuggle with their baby. And so what I'm hearing is this misunderstanding of, when is it okay for me to do skin to skin? When is it okay for me to hold a baby in a carrier? Am I putting them down? And so just clarifying with parents so there's a clear message of skin to skin is really important. We don't want you doing skin to skin and falling asleep on the couch with your baby. But if you want to snuggle your baby after you feed them, like, we know the physiological benefits of skin to skin. So, so those are just a couple examples, and just kind of putting on that cap of how can we empower parents and give them things that they can do and make them feel like they know what to do when they're faced with this decision of following the guidelines and keeping their baby safe at night. So I wanted to shift gears and put on my OT hat a little bit here and kind of talk about some tools that or example of ways that we can give parents tools to use for some of the barriers that parents and babies face with sleep at home. So reflux is a big, we struggled with reflux. All babies spit up, but when it starts causing pain, we start seeing feeding aversions and body tension from posturing. You can see this C-shaped arch of the baby, and seeing that tension start to form in the baby because of those positionings. And so strategies for this, we know keeping the baby upright after feeding is helpful. This can also be really hard to do if you have another kid, if you have twins, and so while you could wear them, there's also using when babies are awake, and again, keeping this within the guidelines of keeping the baby safe, and we're not letting them sleep in this, but helping to prop up babies. If when I was by myself, I couldn't hold them up. You can see my husband looks very sleepy, he's not sleeping, but he's tired, trying to hold them upright. But when can we utilize tools to help with things like reflux, and when is it not appropriate? We're not putting the babies to sleep in these pillows, but we're utilizing them to support reflux by keeping them upright. Also, different burping positions. So instead of having the baby over your leg where their belly is compressed, putting them up over their back and educating parents. And anytime you're compressing that belly, even with tight pants or diaper changes, like you can do diaper changes by rolling the baby from on one side and the other, instead of bringing their legs up towards their face, which compresses their belly. So going hand in hand with reflux is tummy time. And this is recommended, but I think that there's often a missed opportunity to educate about how it goes hand in hand with reflux. And so tummy time is strengthening the core muscles and the muscles around the esophagus, which then is taking the pressure off of their stomach and their esophagus and preventing that food from coming up. And so as babies are able to start holding their head up in tummy time and rolling, especially from belly, or from back to belly, parents start to see a decrease in that reflux. And so educating parents on modified methods. A lot of people say, my baby hates tummy time, or they puke, or how can we help parents get that, because of the direct impact that it has on reflux and therefore on babies being more comfortable when they're sleeping. So there's lots of different ways to modify this, and ways to make it fun, whether the parents on the ground, or we used to set up our boys looking at each other or watching our dogs or whatever, like helping parents to feel like there's options of really getting babies on their bellies. And just for time's sake, this tummy time then is all that strengthening is a precursor being able to sit and eat solids, which again is which helps with that reflux as well. And so my one OT pitch here is that just parents being careful of what devices they're using. So some devices like this that are even sometimes advertised as being supportive feeding seats, they're not anatomically correct. And so they're not really a developmentally appropriate seat for children. So basically the best way to help babies get ready for sitting and eating and all that is actually more time on the floor and not as much time in containers. So here's some pictures of our kiddos doing tummy time in all different ways. So using a positioner to help take some of the pressure off so they could get their head higher and they could see out a little bit better. Then we also did a lot of practice in their high chairs before we fed them. We put toys there just to work on that stamina of being able to sit upright before practicing solids. All right, the next thing is gas. This is a big problem for babies, especially NICU babies, just because they're often on supplements like iron, and the fortification and just high calorie formulas can be hard on their bellies. And so this really worked for us. We utilized simethicone, which is a surfactant that helps make all the little bubbles into one big bubble. But that on its own, a lot of times people say there's mixed results with using that, because what we found is that it doesn't get rid of the gas. It just makes it easier to move. So we would use simethicone, and then we had our little routine here, which my son so nicely demonstrated. So this is the I love you massage, and you do an I, an upside down L,
down all the way to the pubic bone,
and then a U. And we would do that like probably about 5 or 10 times. And then we would do, knees to chest or bicycles. And obviously this can all be modified if the baby has reflux, and then we would roll them side to side. And so we used to do this. Sometimes it only took 30 seconds of doing this, sometimes like 20 minutes straight, because we knew they had gas, and eventually it would work its way out. And it was the most satisfying thing to help them pass that gas through their body. And so again, it can be this, he's almost 2, but for our really fragile infants, maybe it's laying them on their side for a little bit longer and then rolling them. So it can all be modified, but basically that there's a lot you can do with helping them actually physically move their gas through their body. And so this is also one of those water tummy time mats. We found that to be soothing for them, but you could also put warm water in a Ziploc and let them lay on that in tummy time as well. Let's see. Okay. Self-soothing is another big thing that a lot of these sites talk about. This is a big, I'm not going to spend too much time on this, but there's a lot of varying opinions about sleep training and self-soothing and all these things. And I think there's a lot of different ways you can do it, and helping parents to know that there's a way that could work for their baby. They don't have to cry it out. They don't have to do any one method. For us, what this looked like, which was super effective, was up until 12 weeks adjusted, we really were putting them down to sleep. They were pretty sleepy a lot of the time. And then around 12 weeks, we started doing really short timers and giving them a few minutes to try to self-soothe. And if they couldn't do it in that, 2 to 5 minutes, then we would go help them and try again. And so just my take home point with this is that there are ways of teaching this that I think are compatible with all families' beliefs and what they feel comfortable with. But that having a plan to help them self-soothe can help with preserving that sleep for both the baby and parents. Prepping this environment, I've got a couple more. Thanks for sticking with me. These are things, when I was thinking about this, like what can be done before baby comes? This is a big piece that can be done, planning ahead and having the tools in place before baby comes, so you're not frantically trying to figure out what to do after baby arrives. So making the sleep space dark so that it's a cue for baby that, oh, it's dark, now it's time to sleep. And keeping it dark. So when we're doing diaper changes or feedings in the middle of the night, there are fancy gadgets like a Hatch that can do all those things in one, but a night light, or they have these like 3-watt bulbs that are really, this like warm yellow light. So there's a lot of different options. We absolutely have taped black trash bags to windows to make it dark, like whatever you need to do. But that can really help. Again, as Susan said, keeping it cool, both for safety, but also, so the baby's not overheating and waking up. And again, this idea of planning ahead. Obviously, all family dynamics are individualized and a lot are complicated, but coming up with a plan before you're in the moment, trying to figure out what to do, knowing, okay, what are we going to do if our baby has a hard time sleeping? And this, again, is the opportunity in the NICU that parents generally have more time between when the birth of the baby and when they're leaving the hospital. And so this is a great opportunity to talk to families and give them some preparation. Like, you're going home with preemie twins, you need to figure out a plan so that you can sleep, because this is really important for a lot of different reasons, that the parents are sleeping too. So in advance, reaching out to friends and families, coming up with a plan if there's a partner who can help in the middle of the night, whatever that looks like, but having that conversation before you're in the thick of it could be really helpful. With that, scheduling routines, this idea of having, some people are very strict with their schedules, some people don't want to schedule with their baby, but having a rhythm of the day in between feeds is going to help babies to develop a healthy routine as well. And it's going to help them to learn, we can't teach babies how to sleep, but we teach them when it's time to sleep, right? So if they're used to, I get I wake up and I eat, and then I get to look at mom and dad or look at the dogs, and I get to play and see these toys. And then, I get tucked back in and I go back into this dark room. Oh, now it's time to sleep again. And so that's what I was illustrating here, is that it can be really helpful to have a very consistent, and I recommend a short routine. So, especially as kiddos get older, you can keep this routine, but you can change up like bath time, or whether we do several books or whatever the routine is at the beginning, but having a shorter period that is very consistent. So we get our new diaper, we get our PJs on, we either swaddle or half swaddle, and then I get my last feed of the night, and then we turn off the light and turn the sound machine on, and then, a parent rocks me and sings me the same song every single night. And then, having the same phrase, even that we put our babies down. Okay, see you in the morning. I love you. Good night. Whatever it is, we say the same thing. And all of these, which does take time for the baby to learn, but these are all cues. Okay, it's sleep time. It's sleep time. It's sleep time. So again, all around this idea of like, how do we create healthy sleep habits in the family so that the babies are sleeping well and parents are sleeping well? And finally, this is my last point, is helping families to understand and to reach out and to get plans in place in terms of both emotional and psychological, but also physical needs. So there's tons of websites out there. This is 3 of them that I found pretty quickly about that facilitate physical needs for families and getting that, building that community. And they're easy tools to use. People can sign up, bring you a meal. So, because anytime that we can take the burden off the parents, that's an opportunity that they can sleep too, so how can we help families? On Facebook, there are specific safe infant sleep support groups. So parents can reach out to these groups and ask for strategies that, again, are within the safe sleep guidelines. And we can point parents in these directions because there's so much information, and a lot of that information does not comply with safe sleep and a lot of what they're getting. And you can see, through this presentation, it's tempting. You can see why it's tempting for parents to reach out to any information they can get in the middle of the night when they're desperate. And so if we can guide parents and give them support and they feel not alone, because when you're in the thick of that, when we were in that, 12 weeks, that first 12 weeks, it's like, am I ever going to sleep again? Am I ever, is this ever going to be done? But then you look back and you're like, that actually wasn't that long. It is a short time, but in the middle of it, you can't, it feels like there's no end. Even in the middle of the night, you're like, I don't think the sun's ever going to come up today. Like, I'm just going to be here for the rest of my life, rocking this screaming baby. And so having other parents to talk to and vent to can really help parents feel encouraged to keep going and know, okay, this really is only a short amount of time. I can do this. And so again, these are just some more groups that I personally belong to all of these groups. And just the idea of connecting parents so they don't feel alone and they can see the light that this really hard time of when their babies are little is not forever. So wrapping up my take home points that, despite education and intention, that parents report their own sleep as a barrier to adherence, and that really the fact that parents are not getting good sleep is impairing their ability to make those decisions. And so this idea of protecting parent sleep as a way to also keep babies safe is kind of what really stood out to me in preparing for this presentation. And that I think more emphasis should be made on preparing and empowering parents to create a realistic and feasible sleep plan that both keeps their baby safe and protects their sleep. And that is it.
Fantastic. Thank you so much, Emily. Lots of comments. Everyone's saying how helpful this information is. Really, I had 2 full-term girls, and I think this information would have been really helpful, but just to hear that someone else understood what I was going through and was offering some really tangible, concrete ways to get through those long nights. Totally. All right, well, let's open it up for questions. We got 5 or 6 minutes. Feel free to unmute yourself or chat in. I can get us started. So Emily, you clearly have had lots of interactions with the pediatric healthcare system, right? From the NICU to a number of specialists and your pediatrician. Can you recall a time where a conversation about safe sleep felt good to you with a healthcare provider? Like, what worked in that interaction?
Honestly, no. And it wasn't something like I have felt like in terms of safe guidelines, at least like my experience with our pediatrician, it's like we're asked these questions and there isn't a conversation about it. And I don't know if it's because, we say, and it's still true, like, are they sleeping in their own space? Yes. Are they, and we seem to be checking the boxes, I guess. I'm not sure, what that conversation, the only thing I can relate it to is that with our sons, we turn them earlier, not earlier than what is legally allowed and all those things. We turn them in their car seats because of car sickness. And I anticipated a conversation about that with the pediatrician, and it wasn't had. So I'm not, I don't know what that would look like if we said, no, we are co-sleeping, or he sleeps on his belly. We always put him, whatever, if there had been something that came up, what that conversation would look like. But we did, I remember doing the training in the NICU about it, but again, there seemed to be like, it didn't seem like to be a big priority. But then when we went home, it was like, nope, we have to do these things. So, I wouldn't say it was necessarily ever negative. It just wasn't, I didn't have a conversation that felt very empowering of like, I can do this. And here are some strategies and this is what I can do. So.
And it sounds like there was really no opening to have a discussion. It was just like, is your baby flat on your back, or is the baby, in their own sleep space in the crib? I mean, the more that I talk to you and other families, I wonder if the question is, tell me about your baby's sleep and about your sleep, what a typical night looks like, at least as a conversation starter.
Yeah. And I think you said it perfectly before, is like parents want to be validated in the fact that this is really hard. Like, I think even starting a conversation with like, dang, having a newborn is really hard. It's really hard when they won't sleep in the middle of the night. Like, how is that going for you? Like, what is it looking like? I just feel like you would get so much more honesty from parents by acknowledging that like, it isn't as simple as a lot of the information makes it feel. And so then I think parents can really internalize that as like, this should be simple. Like, what am I doing wrong? And then there's a lot of shame around that. Like I said, like a lot of parents who are apologizing for, like, I just wanted to snuggle them. I know I should put them down. And I'm like, like, no, like, I think there's miscommunication happening if you're apologizing, if you're holding your baby, you know what I mean? Like, so yeah, I think coming from it from a place of compassion and like, we really, we know the research is there. Like, this is what we really care about, you guys. And and we care about your sleep. So how can we work with you and help come up with a plan?
Other questions?
Hey, it's Steph. I don't really have a question, but just more of a comment and a thank you, Emily, for sharing this. As a neonatologist for a little while and as a mom of 3 boys, there's a lot of like tips and tricks that you just shared that I feel like would be really helpful for every family. And I think your perspective of being a former NICU mom and an OT and really just like having this true lived experience of what works and what doesn't work. I think we can speak in theory and say, well, for some babies this works and for others it doesn't. But I think having that perspective of, here really is what you can put in your toolkit to know that there are going to be situations where this is going to be really hard, and we can give you some tips and tricks to actually make this more feasible. So thank you.
Totally. And while I was like gathering my thoughts about the tools that we have, I was thinking back to like, well, what do the parents do at 2 a.m.? And the thing is that a lot of what I shared is not necessarily the quick fix for the 2 a.m. thing. You know what I mean? Sometimes there really isn't much that you can do besides you can put them down if they're screaming, or you can hold them. And so my thought behind it is like, okay, well then how do we prevent those 2 a.m. crises? Are we setting up a sleep space where that might be easier, that we can get babies used to sleeping and learning the cues of sleep? Because again, we don't need to teach babies how to sleep. They know how to sleep, but cueing them of when they can sleep and having a developmentally supportive approach to that. And then also from a care perspective, like if parents had a schedule in place, like, okay, if baby's having a hard time, okay, you're taking the 11 to 3 a.m. shift because then you can sleep from 3 to 7 because you have to work in the morning, and having that chunk of sleep before work is whatever it is, you know what I mean? And that's the part that, we could sit down and create a makeshift schedule, but it's not something I could share because it's so different for each family. But that individualized approach, I think, would be so helpful for families of like, do you have a plan in place? Because I don't think you can even anticipate how hard this could feel when you get home. And so I think, and again, like the NICU, like we have contact with a lot of these families for a long time. So it's like, what an opportunity to like really help families feel heard and feel prepared. So.
All right, we are just past 1 o'clock. Well, thank you everyone for joining. Thank you especially to Emily for doing the heavy lifting for this presentation. So lots more information around the defined safe sleep work, which we're calling Sleep Well, to come. And so we look forward to working with all of your different NICUs around standardizing safe sleep care. All right, folks, have a great afternoon and thanks for joining.